toxic goiter. Toxic goiter may be diffuse, multinodular, or may be a single solitary toxic adenoma. Example of diffuse toxic goiter is Graves' disease. Let's discuss the hyperfunctioning solitary nodule, the hot nodule. We already discussed the solitary cold nodule. Now we discuss the solitary hot nodule or toxic adenoma. The features of that are that this one takes more radioactive iodine. Cold nodule doesn't take decreased radioactive iodine. But solitary hot nodule takes more radioactive iodine and it is increased T3, T4 with decreased TSH. This is the thyroid function in hyperfunctioning toxic adenoma. And another feature is that rest of the thyroid gland, thyroid tissue is hypoactive. It doesn't take, see here, this is the hot nodule that takes more radioactive iodine. The radioactive iodine concentrates more in the hyperactive area or hyperactive nodule. But the remaining of the thyroid tissue is hypoactive, take less radioactive iodine. This is here cold nodule taking less radioactive iodine. But this one is hot nodule here, it takes more radioactive iodine. This one has multiple, cold and hot nodule both. Cold takes less. This is multinodule, but hot takes more. And this one is Graves' disease, take uniformly increased radioactive iodine. So what's the cause of hot nodule? Most patients have mutation in TSH receptor, a dominant type of receptor that increases the activity of the tissues or cells in the in this nodule, and this occurs in more than 90% of cases. So what it causes? The dominant mutation causes increased adenylate cyclase activity and cyclic AMP that increases the thyroid cell function. Thyrotoxicosis in hot nodule is mild without features of Graves' disease. And histology shows follicular cells are hypertrophic and hyperplastic with little colloid in them because of the hyperactivity. Colloid is used, so colloid gets smaller and there is marked dilatation of the follicle with flat epithelium. Definite diagnosis with thyroid scan. Demonstrates hot area and suppression of extranodular thyroid tissue. Here, a hot nodule has increased radioactive iodine uptake and remaining of the gland takes less. So radioactive iodine intake is increased and decreased in remaining and the thyroid function is decreased. Radioactive iodine uptake makes the diagnosis, so FNA biopsy is unnecessary in a hot nodule because the chances of malignancy are very little, less than 5% in a hot nodule, whereas chances of malignancy in a cold nodule are more, they are about 10%. And the ratio of benign and malignant nodule is 10:1. Now, when should a biopsy be performed in hot nodule? When the nodule is more than 1 centimeter plus with microcalcification, or it's more than 1.5 centimeters with solid or coarse calcification, or it is 2 centimeter or larger that has mixed solid and cystic components or blood. So these are the indications. Ultrasound biopsy. Treatment of the toxic nodule. 3 treatments: drugs, radioablation, and surgery. Radioablation is the treatment of choice for hot nodule. Why? Because radioactive iodine concentrates in the hyperactive one, not in the normal thyroid tissue. The drugs, antithyroid drugs and ethanol, antithyroid drugs propyluracil and methimazole, and ethanol injection, repeated ethanol injection under ultrasound guidance, ablate the hyperfunctioning hot nodule. Iodine 131 concentrated in the hyperfunctioning nodule but doesn't damage the normal tissue. Disadvantages of radioactive iodine treatment. It may cause hypothyroidism in 10% of cases in 5 to 10 years. It may also cause hyperthyroidism. If you see Wood-Chekhov effect, increased trapping and decreased trapping. And then we have surgery. Surgery, adenoma, enucleation or lobectomy is the treatment of choice for the surgery. Adenoma, enucleation or lobectomy, and before the surgery, beta blockers are given.